Welcome to the Fall 2021 NEDACon. This is a virtual conference designed to bring together individuals and loved ones who are experiencing eating disorders or wanting to learn more about eating and body image issues from experts and community members. This series will focus on research funded through the Feeding Hope Fund, illustrating the breadth and depth of the work in the field and highlighting the ongoing importance NEDA places on funding innovative research. The current panel is expanding treatment access through virtual interventions, and the focus is on how the field can use technology to advance treatment accessibility. And I'm honored today to have guests from UCSD, Dr. Walt Kaye and Dr. Tara Towne, as well as guests from Stanford, Dr. Deborah Safer and Dr. Kristen Runfola. So just to give a brief bio for those aren't familiar with their awesome work, Dr. Walter Kaye, MD, is the founder and executive director of the University of California, San Diego Eating Disorder Treatment and Research Program. Dr. Kaye's current research is focused on exploring the relationship between brain and behavior using brain imaging and genetics, and developing and applying new treatments for anorexia and bulimia nervosa. He was the principal investigator for an international multi-site collaboration on the genetics of anorexia and bulimia nervosa. He has an international reputation in the field of eating disorders and is the author of more than 400 articles and publications. He and the team are treating anorexia and other eating disorders, innovative, intensive program that approaches the problem on multiple levels, including medical, psychological, psychoeducational, and counseling of the family as key support groups. And we'll hear more about that later. Also working with Dr. Kaye is Dr. Tara Towne. She's a postdoctoral fellow at the UCSD Eating Disorder Center, where she splits her time between the intensive family therapy program and treatment development research. Tara has extensive experience with motivational interviewing and cognitive behavioral therapy at Enhanced, and has treated individuals with eating disorders in inpatient and outpatient settings. Welcome, you guys. And from Stanford, Dr. Deborah Safer, MD, is an associate professor in the Department of Psychiatry and Behavioral Sciences in the Stanford University School of Medicine. Her over 20 years of research in clinical work in eating disorders and obesity focus on improving patient outcomes by developing and conducting clinical intervention trials to establish evidence-based treatments. She's particularly interested in adaptations to real-world settings. And Dr. Kristen Runfola, PhD, is a associate professor in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine, where she's involved in clinical care, supervision, teaching, and focus on eating disorders. Her primary interest is in developing and testing the efficacy of clinical interventions designed to improve outcomes for eating disorders, including through the use of technology. Coming to you guys as well. And just to give a brief overview of the projects that they're working on, the NEDA Feeding Hope Fund was pleased to award last year in 2020 one of the award recipients to UCSD for their project New Directions in Virtual and Online Temperament-Based Treatments for Eating Disorders. And the award went to Dr. Kaye and his colleague, Dr. Stephanie Natz-Peck, and Tara Towne is working very much within this group. So briefly, the study aims to address the critical need to develop and test biologically targeted treatments for adults with anorexia nervosa. The treatment model is a mixture of family-based treatment and temperament-based treatments with supports, or TBTS, which we'll hear more about, focusing on psychoeducation of the neurobiology of anorexia to produce an intensive family treatment. The original treatment model was based on face-to-face sessions for 5 days with promising pilot study data in 2017, actually from a previous Feeding Hope Fund grant from Christina Marengo. The virtual model of this treatment now has advantages for facilitating training and dissemination, offering COVID-19 related telehealth benefits that continue, and through pilot data suggesting acceptability and feasibility that are similar to the face-to-face IFT treatment models. And then our Feeding Hope Fund recipient from 2017, Kristen Runfola and Deborah Safer. So their project was called Virtual Reality Intervention Adaptation to Real-World Clinic Setting. And the study aimed to adapt and enhance existing virtual reality protocols for a US population within an adult outpatient clinical setting, leveraging the increased efficacy of a virtual reality, excuse me, VR, to improve outcomes and efficacy of care. Year one of the study focused on operational adaptations of the existing European protocols, including software development, the creation of a treatment manual, and a clinician training protocol for binge-related eating disorders. So binge eating disorder, bulimia nervosa, and other specified feeding and eating disorders that incorporate the binge eating. Year two of the study tested the feasibility and acceptability of the protocol for both clinicians and patients. And today we'll get an update on their exciting project. So without further ado, welcome everyone. I'm honored to be here with you. And we're going to have each study team sort of present more recent research from these projects. And then we'll go into a few discussion questions. So Walt and Tara, take it away for UCSD.
Well, let me go ahead and talk a little about anorexia. And of course, you know, there's both puzzling symptoms and lack of effective treatments. You know, while this is a group of people who have severe restricted eating and emaciation, you know, at the same time, they're preoccupied with food. And they tend to be excellent students, but they have limited ability to learn to change. And they're resistant to engaging in treatment. There's denial and lack of insight. There's often high anxiety and harm avoidance. And, you know, the course of anorexia, even, you know, the group of people that recover, it's not unusual that people may be ill for 2, 3, 5, 10 years before they get better. And there's still a group that remains chronically ill. And there's a group, of course, that there's a high mortality rate. And the thing that we were concentrating on is this particularly lack of effective treatment. And the idea that, you know, maybe we need to learn more about the biologic contributions of anorexia to understand more about these puzzling symptoms, but more importantly than that, how can we develop more effective treatment approaches? And so the question is, why is eating and weight gain associated with anxiety? Why is there lack of motivation and insight? Why is there difficulty learning to change? And what kind of data do we have? Well, you know, there's a certain amount of data suggesting that people with anorexia may be insensitive to reward. The things that normally reward us don't seem to work very well in terms of getting people with anorexia to eat to maintain their weight. They tend to be not only you know, not rewarded by eating food, but you know, don't tend to use a lot of drugs and save money. And there's data suggesting they may be oversensitive to punishment. And not only are anxious and harm avoidant, but actually have difficulty with change and novelty, uncertainty, and repetitive negative thinking. So the approach that we've been taking is really trying to learn more about the neurobiology of these disorders, how, you know, some of these behaviors may be even hardwired in the brain, that they're not necessarily learned, but there may be systems that hardwire some of these constructs in the brain and make it very difficult for people to change and overcome them and develop better kind of approaches to kind of living life and eating food and are more motivated for treatment. So there really isn't time today to kind of go into the complexity of how some of these behaviors are hardwired into the brain. And, you know, I think this is a somewhat controversial area in terms of how people understand this or what people are proposing. But, you know, basically, I think that there's more and more evidence suggesting that there's a certain biologic contribution. And this doesn't mean that it's all biology, but it does mean that there's, you know, biology and genetics really, you know, do make a substantial contribution to developing anorexia. But the approach that we've taken is one of, you know, it's very difficult to change temperament and traits. And then is there a better way of approaching this? Can we teach people with anorexia more constructive skills and strategies for dealing with this kind of temperament and be able to overcome these traits? You know, this is not a foreign concept in medicine. For example, you know, if you're blind, there's very little we can do, you know, to make people who are blind be able to see, but people can learn constructive skills and strategies to use other senses to navigate the world. And this is kind of the approach that we're taking in anorexia. So I've been fortunate enough to work with some very, very talented therapists, Stephanie Natz-Peck and Laura Hill and Tara Towne and Christine Weinrega, who could really start to take some of these ideas and start to turn them into more constructive kind of strategies. And I'm going to let Tara do the hard work here and really explain what these are.
Okay, so one of the things that we try really hard to do at UCSD is to translate the findings from our neuroscientists into clinical treatments. And so TBTS, or temperament-based treatment with supports, as Walt said, was initially developed by my colleagues and superstar female mentors, Stephanie Natz-Peck, Christina Ringa, and Laura Hill, as a treatment for anorexia nervosa. And I think what's different about this treatment is that it is informed by this biologically based understanding of eating disorders. And we think this is really important for a couple of reasons. First, for families to really better understand eating disorders. So through different experiential activities and conversations that we have in TBTS, we really want families to come away feeling like they understand that no one chooses to have an eating disorder and that no one in the family is to blame for the development of the eating disorder. And I think when families really understand that and truly believe that, they often feel empowered to move forward in recovery without the burden of that guilt and shame. And then, secondly, I think with this biological understanding, it's really evident in the way that we implement interventions and the way that TBTS is structured. And so, in traditional eating disorders treatment, there's often a focus on changing a lot of the temperament traits that Walt was mentioning. And so you hear things like perfectionism or rigidity get identified as targets to intervene upon. But we do have a lot of evidence that these are things that are not only biologically influenced, but also persist even in recovery. And so what TBTS does differently is we really want to play to the strengths of these temperament traits. We actually think it's really amazing that people are high achieving and think about the future and, in many cases, maybe are risk averse. And so we want to help them manage those traits in a way that actually promotes their recovery. And so, this treatment has been implemented at UCSD in the form of intensive family treatment, which is our 5-day multifamily treatment, where historically 4 to 6 clients and their families would travel to UCSD for 40 hours of intensive treatment, where they're learning a lot of these things, but more importantly, they're practicing it in a way that's going to allow them to move forward upon discharge. And so what we're doing now is we're trying to translate this treatment to a virtual approach that's more accessible and affordable for people. And so how we've done this to date is through virtual intensive family treatment weeks, where TBTS is the primary treatment intervention. So to date, we've held 6, soon to be 7 intensive family treatment weeks virtually. And families have just really highlighted a lot of the benefits. It's so funny, everyone who came in person to attend a multifamily treatment week would always say, we're so glad that we took the time to put everything aside, travel to San Diego to do this. But now that we're doing it virtually, people are saying, I'm so glad that I got to do this in my typical environment. I'm so glad I could do this for the comfort of my home, that I didn't have to disrupt things in order to receive this treatment. So I think that's a huge advantage to this modality. And on top of that, we know that one of the major risk periods for relapse is when people are discharging from a higher level of care. And so we hope that by people implementing these skills in their typical environments, that they're avoiding some of the difficulty of making that really difficult transition back to typical life. And so with the support of NEDA, we have been creating more virtual resources that we've been using as both a supplement to our multifamily treatment weeks, as well as hopefully some type of virtual platform that families can access and go through in more of a self-guided format. So to date, we've created about 40 3 to 10 minute treatment videos that feature clinicians, researchers, experts by lived experience, talking about either their personal experiences with recovery, that journey, as well as different treatment strategies to implement. And so, the format and the next steps for those resources are still to be determined, but at the end of the day, our major goal is accessibility and affordability of treatment so that more people can be helped with TBTS.
Great. Thank you, Walt. Thank you, Tara. That was really informative. Kristen and Deborah, would you guys like to give us a brief update on your study and some of the findings?
And just to say what an amazing resource you have at UCSD. We really appreciate that opportunity for our patients. So thank you. So the title of our talk is Through the Looking Glass, Adapting Virtual Reality-Based Treatments for Eating Disorders to a Real-World Clinic Setting. And just as a little bit of background, binge eating disorder and bulimia nervosa are two eating disorders that are characterized by binge eating. And this is where people feel out of control over eating and end up eating large amounts of food in a short period of time. And this is often associated with really extreme feelings of guilt and shame, disgust feelings that can make it really hard to do things that are important to them and really can impair functioning. We know it can cause serious psychological and medical consequences. And unfortunately, we do lose people to eating disorders. We have effective treatments, as Dr. Kaye mentioned, but up to 50 to 60% of the patients don't fully respond to our standard treatments, such as cognitive behavioral therapy, and too many still relapse down the line. So alternative options are needed to help us improve our outcomes and help sustain recovery. So virtual reality is a technological tool that we're finding can supplement our evidence-based treatments with the possibility of helping us enhance outcomes. And we're seeing this across disorders, especially in the PTSD and anxiety literature. There's been some well-conducted research in the eating disorder space now that's shown that cue exposure therapy and emotion regulation protocols in particular can benefit from the use of virtual reality. For example, European studies show that in patients who did not respond to cognitive behavioral therapy, a VR-based program was better at reducing eating disorder symptoms than continued CBT alone, and those effects were maintained for 6 months. There's some research now showing that there's an increased motivation for change in VR environments and less dropout compared to in vivo active comparisons. And we think this may be partly because VR can be experienced as safer in a more controlled environment than the real world. But yet VR allows patients to interact naturally with a computer-generated experience that represents the real world and getting support from a specialist while they're doing that. Also, because it's virtual, clinicians and patients can avoid some of the logistical difficulties of actually getting foods to the office or the home, or going places that can be what is considered high risk, such as restaurants, which requires having to travel to and from different settings. We do know from some of the neuroscience and behavioral research that virtual foods are generating similar emotional and behavioral responses as actual food. So despite this work, there's been minimal adoption of this type of treatment in US clinics. And this is because past studies have been conducted only in research settings under really tightly controlled conditions, and then also only within Europe. So there was a need for studies to show whether virtual reality could be adapted for our real world clinic settings where there's much more diverse patients, and that our protocols can be effective in US patient populations. So we're really grateful to NEDA to have access to some funds to be able to develop culturally adaptive, clinic-ready, virtual reality and immersive treatments for eating disorders. And then as part of that process, to develop a comprehensive therapist manual that we could use to easily disseminate that program to other clinics. So our first study focused on pilot testing the virtual reality cue exposure treatment, since it had the most solid evidence behind it, specifically targeting binge eating behavior. In short, this is a treatment that's typically designed for people who have strong urges to binge eat in certain environments, like a restaurant or when they're home alone in bed, for people who feel anxious when they're exposed to those situations, might fear losing control over eating and so want to avoid them, and end up feeling out of control over eating. So for some people, they just notice that they automatically start eating in specific contexts. And this is a program that we use to help people confront those challenging situations and manage their urges and their cravings and their uncomfortable feelings without binge eating. So the goal of this is really to help them develop a greater sense of safety and control and efficacy in those situations, and hopefully down the line then to reduce the cravings and urges that were typically associated with those environments, or just to be able to better manage them and tolerate them. So our primary aim, because this was a pilot study, was to make sure the treatment was feasible in an eating disorder clinic, that it was acceptable to our patients and therapists, so that people were actually interested in using VR and satisfied with the treatment. And then we wanted to make sure that we were still seeing trends in the right direction, that we were seeing a reduction in binge eating, frequency and severity, and that we're helping people better tolerate their emotions. So our participants were recruited from our outpatient eating disorder clinic, and this was pre-pandemic, so people were still in the office. And these were all adult patients. These were people who had been previously diagnosed with an eating disorder, had completed prior treatments such as cognitive behavioral therapy or dialectical behavioral therapy, but they continued to have at least once weekly binge eating episodes. Treatment was delivered by therapists of specialty in eating disorders over 7 to 8 weekly 60-minute sessions. And we used a protocol that was adapted from some researchers in Spain. And we had interviewed eating disorder specialists and those with lived experience in the US. We reviewed scientific literature and then updated the protocol to make sure that it was consistent with that was culturally appropriate and consistent with the US norms. So for example, the specific types of foods that we were presenting are what you would see in the US. This resulted in our first comprehensive therapist manual that therapists used to guide their treatment. And the program was administered through laptops using Steam VR as the platform. And then we had Oculus Rift headsets, which allowed participants to be completely immersed in the environment and then also isolated from the office or the real world. And we had Oculus sensors and controllers that were used to manipulate food in the environment. Treatment consisted of an assessment phase of up to 2 sessions, followed by an intervention phase of up to 6 sessions. And the assessment portion, we were really trying to understand the different triggers and cues that participants had. They're introduced to the program. We set expectations, for example, that food wouldn't look 100% realistic, and that they were then exposed to 30 different common binge foods and 4 common environments that we know are high risk for binge eating. So this would be like the kitchen, the dining room, the bedroom, or a restaurant. And then as people were in these environments, they were indicating their degree of anxiety and craving on a scale of 0 to 100. And then at the end of that assessment, the program generated a hierarchy of the top 13 most anxiety-producing food environments, which were then later used in the intervention sessions. And those exposure sessions included what you would typically have in a therapy, so like a check-in, homework review. We would do active exposure of up to 30 minutes, where they were in the environment experiencing cravings and urges with a therapist coaching them through their experiences. And then, of course, they weren't binge eating as they were sitting in that environment. And then afterwards, we had post-processed what they experienced and talked about any lessons learned. And then from there, we would set additional exposures that they would complete throughout the week and home to generalize skills. And then sometimes we would do some skills teaching. We had 11 people participate in our study over 7 months. And overall, we found that the treatment was feasible in our clinic. We had 63% of our invited therapists participate. So 5 out of 8 of the therapists we wrote, inviting them were interested in dedicating non-compensated time to actually learn the treatment and the technology and implement it in their office. 82% of participants completed treatment with 2 dropping out. 1 was due to an injury unrelated to the study, and then 1 was due to tech issues. We had on average participants complete 6 of 7 sessions, and the patients found the therapy acceptable. There were minimal side effects experienced in VR, so we might worry about simulator sickness, but our numbers were comparable to what you would see in other VR environments, and then less than what you experience in gaming settings. Participants rated the intervention as compelling and that they found it was both immersive and involving. So basically the environments felt consistent with what you would experience in the real world. And then mean scores on our common satisfaction measure, which is the CSQ, were high at 28 out of a possible score of 32 for both patients and therapists. Though we didn't focus on effectiveness in this study, we did find that all participants had reductions in binge eating and purging after treatment and at 6-month follow-up. Over just 7 sessions, 55% of participants were had completely eliminated binge eating. And this is noteworthy because, again, this is a sample of patients who had not completely responded to their prior eating disorder treatment. And now Dr. Safer is going to talk a bit more about what we learned as she talks about our second intervention.
So we ended up having enough time to do 2 studies. So we started with the Q exposure, and we noticed that some of the patients were indeed finding that they were experiencing urges and anxiety with the foods that they were being presented with in the virtual environment. And some patients seemed to need some sort of emotional prompt. They were emotional sort of binge eaters. It wasn't so much the hedonic only. And so that led us to become increasingly interested in exposure to emotions versus exposure to food. And so we got interested in emotional eating, which is a broader area. I mean, many binge eaters are emotional eaters, some are not, and some emotional eaters are not binge eaters. And so that was, we made our study because we see a lot of emotional eaters, or people start to improve from the objective binge eating, but continue to have emotional eating that's bothersome to them. So the aims of this study were primarily to reduce the severity and frequency of emotional eating, and also to reduce emotion dysregulation and reduce psychological inflexibility or avoidance. So how did we do this? Well, clients received either the intervention, or we did have a comparison control of treatment as usual. So those who received the intervention got 7 sessions that were 50 to 60 minutes each, comprised of an assessment session, 2 emotion regulation sessions, which I'll describe, and 4 emotional rescripting sessions, which I'll also describe in the next slide. So here are the this is just an example of one of the emotional regulation sessions. It's the waterfall on the prairie. And so originally we were intending to deliver this treatment with Oculus Quest so that they could be immersed. However, with COVID, we had to pivot to a 2D delivery where we shared screens with these immersive experiences. So the aim of the 2 emotion regulation sessions was to increase the patient's awareness and ability to recognize their emotional states. And then they had homework where we would give them an audio version of the immersive experience so that they could listen to, and then, practice, let's say if that was the emotional awareness, or if, especially in the beginning, it was sort of recognizing a sense of calm and safety, so a chance to practice that. Then we had 4 emotional rescripting sessions. So these were immersive metaphorical journeys. So here's a mountain and a backpack. It's a little hard to see, but anyway, and these were used to expose the patients to the painful emotions, helping them to rescript their experiences to these emotions so that they'd be less likely, theoretically at least, to trigger future emotional eating. And when there were positive experiences, we worked to amplify those positive emotions. And they also received homework where they could listen to the audio version of these immersive experiences. So how did it go? Just like in our first study, this was a small study. The aim was really on feasibility and acceptability. So it did seem to be feasible. 100% of our patients completed the treatment, and on average, they attended 6 out of 7 sessions. They seemed to find it acceptable. We did check for cyber sickness, even though it was a 2D delivery, but we didn't see evidence of many side effects, and good satisfaction, maybe not quite as good as we were seeing. And that, in my sort of guess about that, is because the 2D wasn't quite as immersive as the 3D would have been. But still, this seemed good, and the therapy worked for those in the VR group compared to the control group. So we found reductions in emotional eating from a frequency of sometimes. So I guess they weren't doing it all the time, but there were sometimes down to seldom, which seemed significant clinically. And also, this was as I said, a significant difference in the small little study of the small sample size compared to the treatment as usual. So in summary, again, we're thankful to NEDA because we really are passionate to increase access to care, break down barriers related to clinician adoption of evidence-based treatments. And so this study enabled us to study these things. And we found preliminary evidence, as Kristen already showed, that cue-based exposure protocols could be adapted for US audiences in real-world clinic settings. We also found that these 3D immersive regulation experiences could be delivered 2D, and that both protocols demonstrated acceptability, high acceptance, and at least good satisfaction, assessing both clients and therapists, and there was evidence of high feasibility. And I think most critically for us, especially given some of the things we're going to talk about in terms of barriers to care, a big one is lack of providers. And so we were using this sometimes when patients would come in, they'd be assessed in our clinic, but we had nobody to really take them for a longer term psychotherapy evidence-based treatment. So sometimes we would give them this, which were short 7 to 8 sessions, could be learned by graduate students to use, at least not so much for the cue exposure, but for the immersive emotion regulation ones, to show preliminary evidence of effectiveness. So we found that the VRCET patients were better able to manage their cravings and urges to eat, more likely to be abstinent. And the patients in the immersive emotional experiences were better able to regulate their emotions. And interestingly, as Kristen already pointed out, these VR environments did not need to be perfect. We noticed improvement. Again, in both cases, we recruited patients who had already received treatment. And the durability, though, for binge eating is a concern. And so we're thinking that future iterations should include some means to improve maintenance of effects, such as the booster sessions or self-administered sessions at home. Here is a URL for one of the papers that came out of this, a call to use deployment-focused model of treatment development. So instead of the 17 years that often it takes for something to go from research to a clinical setting, to try to move more quickly. And this one was on translating virtual reality into a real clinic setting. And this is the results of the study that Kristen described, our uncontrolled pilot study. And we're still working on analyzing the results from our emotion regulation treatment. So thank you.
Thank you so much, Deborah and Kristen. That was amazing, as well, and Tara. So Deborah, you touched on this, and Tara and Walt, you did as well in your presentations, but one of the discussion points that we wanted to get into is what are some of the challenges that families in the US face when they are seeking treatment?
Yeah, I think we all sort of see, as you're saying, that one of the factors is the lack of providers, not just even evidence providers who have evidence-based treatment in disorders. Now we're just seeing lack of providers at all. But so, and the need is going up, especially around COVID, with the resurgence of so access to care, meaning not enough providers or distance from providers. I think in some ways the fact that we can do virtual treatments, I mean, certainly is a help to that, but we're in terms of looking at access, there's costs. I'll let you, Tara. I mean, I think we agree on what these are. Do you want to add anything?
No, I mean, that's right along the lines of what we're seeing clinically. I think the less access you have historically, the costlier it is to seek treatment, because you end up having to relocate for treatment. And then, that doesn't necessarily mean that you're seeking an evidence-based treatment. So there's sort of a confluence of problems here, but I think, the virtual treatment can really be of benefit to people who are far away from care.
So one of the things also Tara had mentioned before, we had a brainstorming session here, was the barriers have a real impact on an individual's ability to seek treatment. So we know that about 80% of people with eating disorders never receive treatment. And that has to do with all of those access barriers, including even getting in the door and getting a diagnosis. There are many people that have all of the symptoms, all of the impairment in functioning, but they're in an area such as a rural area where there really are no providers. There might not be access to anyone to help them even get in the door. And then Tara to also point out, we know that both longer length of illness in general, so sort of chronic or severe enduring, and longer length of illness before accessing treatment. So if there are many years that are built up before that person gets in the door, they're both associated with worse prognoses. So many people miss out on that critical window of the best chances for recovery. That being said, anytime anyone has a chance to access treatment for recovery, it's definitely worth it. Go for it.
About access, and you may have already said this, is just the financial barriers being a big one, and especially with insurance companies making it hard and disincentivizing different providers from being on panels because there's just such cumbersome paperwork, or they're not really good at reimbursing services. And so that pushes some providers in private practice to stay off insurance panels. And so people having to pay off out of pocket and not being able to do so, or providers only being able to offer a few slots every week for sliding scale fee patients. So that's a big one. And also about the access, there's certain populations that have disproportionate access than others. So there was a study in 2016 that looked at 100% of the residential based eating disorder programs in the US accepting females or female identifying patients, but only about 20% accepting people who identify as male.
Mm-hmm.
So like specific groups of people are also just not able to find a clinic that's going to best fit their needs and feel safe for them.
Yep. I agree.
You know, and the other issue,
sorry, go ahead.
And the other issue is this one of kind of motivation and insight. And you know, certainly a certain group of people with eating disorders that don't see themselves as having a problem. And you know, how can we better understand that? How can we portray our treatments, you know, in a way that is more appealing and more motivating to people that don't want help or don't see themselves as needing help?
I was also going to add, and this goes back to TBTS. As we know, comorbidity is the rule, not the exception. So there are a lot of people that are coming in and the presenting problem is an eating disorder, but there are significant concerns about anxiety, depression, you know, fill in the blank. And not every program is equipped to handle that. Not every program can do it at the same time. So sometimes frustration will be, well, I went to this eating disorder clinic and they said, well, we can't fix the bulimia until you fix the depression. And so they sent me over there and back and forth. So it is confusing. It is overwhelming. And Tara had noted this in the brainstorming that families, you know, are often just in this black hole of where do I go? I don't really understand. It's a maze that's not clear to anyone. And so another barrier could be, you know, the parents just trying to navigate everything. There could be things out there, but they may not necessarily know because it's not a straightforward process. So, you know, part of the idea is to sort of, you know, simplify that and make it clear, you know, what the resources are for people. So moving on, being mindful of time, of the next brainstorming topic, it was, what have you learned or hope to learn through your research findings? So as I've touched upon it, but maybe talk a little bit how you started your virtual therapy treatment pre-COVID. You guys were ahead of the curve. But now, you know, coming into COVID and hopefully coming out of COVID, but going forward, you know, as Tara said, like virtual treatment, teletherapy, telemedicine is here to stay. How do you guys see the projects continuing to advance, given this is our new reality?
Yeah, like one potential use of our virtual treatment resources, I think, is not just to supplement increased access to care, but also to train providers who might not otherwise have the opportunity to learn or to see eating disorder patients, you know, even on an outpatient basis. And so we're hoping that they serve a dual purpose to really, you know, increase the number of available providers we have to help people. And then I think, you know, what we're hoping to learn is, and this is TBD, but we're collecting data to see if hopefully our treatment has the same efficacy in person as it does virtually, because I think virtual treatments are here to stay. And for many, it's actually the preferred modality of treatment right now.
Yeah. And you had mentioned that, you know, the feedback thus far is families were pleasantly surprised to note that when the treatment was in the home, in the natural environment, with all of the usual obstacles and challenges, that it was really helpful because you're applying it to the real world right there. There's not that challenge in between. Okay, well, everything was fine at the clinic with all of the structure and support, and now we go back to the home, right? So
exactly. And, as a clinician, it's incredibly useful to just have the chance to observe that too. Whereas, as you mentioned, like it might be a totally different presentation in a clinic just because of the uniqueness of the setting.
Yeah. And I remember I was, when I was visiting there, one of the pieces of feedback from some of the individuals was that, again, unexpected benefit, but when they were in the privacy of their own home, they felt more confident sharing how they were doing and how they were feeling versus if they were in the clinic and maybe they were in a group setting, it might have been a bit more intimidating. So for them, they felt safer in opening up. So that seemed to be another benefit.
I think that's particularly true for, we're primarily working with teenagers and young adults. And so for young people, that's very much their world in the past couple of years. It's, electronic connections and being at home. And so why not do treatment that way as well?
Yeah. And we had also talked about, everyone's on their phone now, and in working also with university students. If someone's like walking and looking at their phone, no one's going to assume that they're doing anything related to therapy, right? Because it's so normal. So it kind of normalizes it. And as we all know, especially with COVID, talking about mental health in general has become much more normalized. So there's some silver linings.
Just to pick up on one of the things that Tara said, it's still, I think provider training is critical, but there really is a lack of the number of providers in California. I may be wrong on these figures, but if there's 40 million people in California, I think there's something like 6,000 psychiatrists, like 25,000 psychologists, another 60,000 social workers. I mean, it's really not a large population to train mental health facilities for a huge population. What can we do about taking these kind of treatments and doing direct, developing treatments that, people that can use in their own home, without even a therapist, can use in a very kind of economical kind of an effective kind of way, because, it's going to take a long time to train enough providers to really, treat everybody that's, that needs help.
Deborah, do you guys want to add anything from the Stanford perspective there?
Yeah, I was just going to say that, that's something that Walt just brought up that we're very interested in looking at unguided self-help through platforms, through videos. Sort of what you're saying is a lot of the content that you have, but delivering it without anybody doing that, something that absolutely makes sense. Krista, I don't know if you.
Yeah, no, I'm just thinking about even the exposure protocols through a computer. If it's, we talk about the virtual reality and maybe feeling a little bit safer because it's more controlled, but also maybe feeling a little bit safer not having the therapist actually in the home of the person. Having that computer space might be helpful in doing, we already do kind of virtual meal support and recognizing that it's easier for me as a provider to provide meal support to my patients in the home. So I think just it's nice to have the options. And while I think maybe just piggybacking on what you were saying, it would be really nice for us to have be able to practice cross state lines. And we had a brief period of time where we were able to do that. But continuity of care is a huge issue. And sometimes the lapse in care, just trying to transition between providers, makes a difference in someone's ability to maintain recovery versus relapse. And so if we can continue seeing those patients who are leaving for college or who are at college and start slipping and they can come back to us, it would be really nice from a continuity standpoint.
Kristen, I can't stress that enough because, as you alluded to, there was those emergency COVID laws that allowed us temporarily to practice across state lines. And, now that a lot of those have expired, people that are seeking treatment from our 1-week program that are out of state have to fly into California to have virtual treatment, which of course is extremely inaccessible for the vast majority of people and completely wipes out a lot of the benefits of telemedicine. So it's been really frustrating, and I'd love to see those laws catch up to the technology that we have.
Yeah, I was just going to mention that, yeah, on the one side, the laws and all of that are really prohibitive in these ways, and that, but just as you said, the technology is increasing so quickly. And so, I've sort of I'm thinking sort of about how to make our virtual environments even more valid in terms of not just the foods that we model, but like there's a hoarding study that Carolyn Rodriguez is doing at Stanford, where they got 360-degree pictures of the rooms, and then they were able to sort of get some undergrad, I think, to model certain real objects that they could then practice, experiencing. And I think we would love to do that for like somebody's kitchen or something like that.
Yeah, I think there are a lot of potential, options for where this could go. Hopefully some regulations will be eased as, the data comes in and people find that, oh, this is cost effective and it's acceptable and it's feasible, and maybe it's in our long-term interest to keep that flow going. Okay, so wrapping it up, final question. How can those of us in the eating disorder advocacy community work to address some of the barriers that you're identifying in your research? What can advocates do, like people associated with NEDA, people that are, in sort of advocacy roles like Eating Disorder Coalition, et cetera?
I mean, I know that a lot of people in advocacy communities have lived experience as a parent or a support person or someone who has experienced an eating disorder. And I've had the privilege of getting to work closely with a lot of these people and making these resources. And I just can't say enough like how valuable it is to hear their stories and the way that these barriers have impacted them and what they think that we should do about it. I think, one of the most powerful things is like when our data is like personified with their experience and the story that they're willing to tell. So I would say like just keep telling your stories because they're really, really powerful in affecting change.
I think being able to have, NEDA does a good job of this, the 24/7 like hotline numbers and educational resources that are available online, and using social media as a platform for educating people about what treatments do exist, how they can find treatment, what is considered good treatment, and continuing to put efforts there. Since so many people are online right now. I've had a lot of people come to me and say that one of the first people they spoke to was someone through like NEDA or through one of the community organizations to learn about where they could find a therapist.
And one of the things I think advocates could do is help to support people like Kristen and Tara, who are, smart and skilled and dedicated to developing new treatments, but, need this, kind of the support to do research and treatment development.
And that's where Feeding Hope Fund comes in. And to circle back to the beginning, Feeding Hope Fund specifically is targeting early career researchers to provide them with sort of startup funding or seed funding to get that pilot data to then be able to apply for a larger NEMH R01. And, as our track record with you guys and everyone else shows, it's really a great investment, and it allows everyone to take that, crucial first step to then build upon the research and really change. So I wanted to thank you guys once again for all of your hard work, for really being model NEDA Feeding Hope Fund recipients, and for taking the time to get together tonight. Any final words before we close? For people who are listening who maybe are struggling, that just like I hope this doesn't create a sense of hopelessness, that there is a lot out there and accessible. And one of the things that I did appreciate learning through our study too is that even those treatments that demonstrate effectiveness through our research, even if they don't work, it doesn't mean that there's not something else that might work for you. And so to keep trying and not give up.
Yeah,
thoughts?
I think that is like what you said, Kristen, is that was our first bullet point about it was, there is hope.
Yeah.
Yeah.
I think where advocacy is so important also is like, the eating disorder tells you that you're not sick enough or that you don't deserve treatment. And then our kind of media has perpetuated the stereotype if you don't sort of check the boxes of what like a stereotypical eating disorder looks like. And so, reaching out to communities who like historically are underserved and can't access treatment is huge. And I think that's probably best done by someone, who has personal experience with it.
And one of the things that we're learning is that people that have these kind of temperament traits, once they start to use them in positive, constructive kind of ways, actually do great in life. They do very well, and they can really be advantageous in terms of accomplishing things and doing well. So, I think that it's a question of how you learn to use these things in a beneficial kind of way.
Thank you guys. And to wrap it up, I didn't speak about this in the beginning, but for people who don't know, I have my own lived experience with anorexia for 23 years. And I've been recovered since 2012, and all of the premorbid OCD traits are still there, but the perfectionism led me to be very successful in life. I went to undergrad at Brown, grad school at Berkeley. I was a professional ballerina, and I'm the one that organizes all of the projects for home base at Brown and then remotely at UCSD. So there is hope for recovery even after 23 years, and you can be successful in life and you can use your talents and skills to help others. So just wanted to leave you guys with that. But thanks again, everyone, for participating in the panel. It's very, very helpful. I'm sure it's going to be really informative to a lot of people.
Yeah,
Thank you for having us.
Thank you.
Perfect.
Thank you for having us.
Yeah, thank you.